So the title of the dissertation is Assemblages of Patient Safety, Bringing Together Matters of Concern Between Design and Multiple Knowledge Practices in Healthcare. The candidate is Angelos, Balatsas-Lekkas from the DTU Management Engineering, Division of Technology and Innovation Management. And last minute changes. So on the supervisor team, we have Yutaka Yoshinaka from DTU Management. We have Associate Professor Ove Koberg, also from DTU Management. And we have Associate Professor Jamie Walls from Aarhus University, being here. And in the committee, we have Christian Bock from DTU Management. We have Christian Clausen from Aalborg University. And we have Tue, and I can't see.
Teun.
Oh, there it is, Teun Sudan Yarak. And with that, I'll leave the floor to the candidates, and you have 45 minutes.
All right. Thank you. So I'm just going to read the title one more time, which is Assemblages of Patient Safety, Bringing Together Matters of Concern Between Design and Multiple Knowledge Practices in Healthcare. So this is the outline of the presentation. So we're going to have an introduction. I'm going to present the objectives and relevance of this project, some elements of my motivation, some areas of concern in research where it's the context where I position my PhD project. Then I'm going to move to the research questions and a brief mention of the theory. Then I will move to the methodology, and I'm going briefly to present the methods I used, the empirical scope, some methodological considerations for studying patient safety practices, and I'm going to conclude this section by referring to the articles that go together with the PhD dissertation. Then I will move to the cases and findings, and I have 3 cases. One is about scenario design in healthcare simulation, one is about young patient hygiene, and another is about clinician and designer collaboration in public hospitals. And finally, I will move on to discuss findings across cases and to present also some elements of a generative framework. And this will become more clear in the later part of the presentation. So let me begin by briefly sketching out the 2 main objectives of this project. So my first objective is to understand how the use of particular devices within healthcare settings may relate to the design of new devices and services for care delivery. And I deem such objective to be relevant for professional designers, but also to healthcare professionals who have an interest in design and who all together at least aim to appreciate the kinds of changes or consequences that new devices and services may potentially bring in care delivery work and more generally in the context of use. My second objective is to put my observations about the use of particular devices into perspective and conceptualize or present a conceptualization of how design as a process may take place within healthcare settings. And this objective relates also a bit closer to some research communities that inquire how design emerges as a form of practice in professional fields that they are not necessarily acknowledged as professional design fields. So we talk about how design may take place outside of professional design fields. This is just to give you an idea of my motivation about why to study healthcare and patient safety actually within healthcare. So the area actually that I'm studying is the collaborative work between healthcare professionals and their efforts toward the smooth treatment of patients. And this is the place where I try to study the design and use of particular artifacts. And early in the PhD project, I came to sort of realize almost a paradox. On the one hand, you see like risk and potential for harm to be almost inherent in the daily work of healthcare professionals. On the other hand, thankfully, patients come out most of the times safe, or at least they receive safe treatment in the hospitals. So I was wondering, how do these 2 things actually coexist? And something which is related with that is, or that was actually another part of my motivation, which came after some initial observations, was about why actually healthcare professionals deem collaboration to be as an important aspect for delivering safe care. The three areas that you can see here in this slide constitute the research context in which I want to position my PhD project. And the one is design for patient safety, and the relevance that design practices may have for the safe treatment of patients has been already a concern in a body of literature which is mostly informed by the very broad field of human factors. And this perspective suggests that safety can be improved by developing models and artifacts or services out to support the delivery of safer care. An example could be, for example, a model for actually writing down errors or causes of errors that happen again and again within a hospital. My point of departure is a bit different. I'm interested to learn about design in healthcare by studying the consequences that models, devices, and services have in the work of the healthcare professionals. The next one is patient safety practices. And the study of patient safety practices is also a rather broad field, which may concern the work of safety experts or the work of policymakers who have as an explicit objective the improvement of safety. I approached patient safety practices by focusing on situations where everything worked as it's supposed to do, and by drawing on the research of other scholars who have been doing the same before. I was more interested in finding what constitutes safety in the work of healthcare professionals. The third one is what I call design and use, or relations between design and use. And my interest about this relation is supported by a literature that offers concepts where these concepts actually describe how actually design may continue into the context of use. And this has appeared in older and more recent publications under different kind of headings, like design in use, design after design, continuous design, or design in the wild. Drawing on such ideas, I approach design as a process that concerns, of course, the technical work which is necessary to develop a new artifact, but also the interactions that such artifacts invokes to those actors that they actually use it. And here you can see the research question and sub-questions. And I can say that my main research question is about understanding the makeup of patient safety practices and the relevance that this may have for understanding collaborative design in healthcare. And the two sub-questions that I have below have helped me actually to approach the main research question step by step. So the first one is about understanding what is patient safety practices for the healthcare practitioners. And the second one is about the value of collaborative work between healthcare professionals for understanding collaborative design within healthcare. So I try to take it step by step. My project is theoretically informed by notions that have concerned the interdisciplinary field of science and technology studies. And I won't refer extensively to such notions, but I'll just mention some important ones, or some I have been concerned mostly. For example, the notion of assemblages, which is developed in the works of the authors that you can see below, like Deleuze and Guattari, in the very old text, has helped me to analyze patient safety practices by attending on how these may change over time, what is the role of materiality in them, and so on. In other words, assemblages have helped me to understand what makes up a patient safety practice. A set of object-oriented notions has helped me to analyze the role that artifacts play in patient safety practices. Boundary objects have helped me to focus on the coordination that takes place in the collaborative work between healthcare professionals, as well as the boundaries that such kind of collaboration generates. Intermediary objects have helped me to attend to the representations of safety that healthcare professionals may make or may use during their daily work. Epistemic objects allowed me to understand the different uses that artifacts can afford, and how such uses actually could affect the collaboration between healthcare professionals. And finally, conscription devices brought me closer to understand how actually healthcare professionals participate in the development of artifacts during their daily work. So I'm going to turn now to the methodology for studying patient safety practices. And firstly, I will lay out the methods that I drew on. Then I will briefly present the main empirical settings where I did my fieldwork. Then I will lay out some methodological considerations for studying patient safety practices. And finally, I will mention the 2 articles that come together with my PhD dissertation. So I studied patient safety practices by conducting a form of ethnography with support from interviews, participant observations, and workshops with participatory engagement. And I'm just going to give you an idea of these kind of methods, how these kind of methods are put to work. For example, here you can see this is a photo that I shot during an interview with an informant after I have been doing some observations. And I have been shooting some photos during the observations where I took them with me while I was doing the interview to actually allow her to reflect on the way that she was working. It's not of bringing this kind of materials as a matter of evidence, but as a matter actually to invoke kind of thinking during the interviews. Here you can see a photo that I shot during while I was doing participant observations, and that was actually to help me get back to the same situation, because when I was there, I deemed it quite complex, and I wanted to have something more than just notes to remember how it was when I was doing observations. And here you can see 2 workshops that I did during the PhD project. In the upper picture, you can see it is a workshop with some informants and gatekeepers from a particular case organization. And I did that for generating data. And the other one is a workshop that I did early in my PhD with my co-supervisors and my supervisor, where at this point of time, I considered them as sort of informants that they could tell me at least, or they could give me some information of where or what to study in patient safety practices. So I tried to use them in that way. So during, I can say that during my empirical study of patient safety practices, I followed 3 principles which actually position my study in the category of interpretative research. And the first is that I actively participated in the generation of data by actually interacting with the participants. So I didn't do any kind of desktop research. That's the point here. I also expected that my interactions with the informants would be beneficial for them too, instead only for me. So I've tried to make them to motivate my informants to reflect upon their own work and also gain something out of it, but not pushing only my own agenda. And during the generation and analysis of data, I expected to study or to conclude to something that is more than a single truth. And it was probably a search about multiple truths about particular events, of course. Now I will briefly present the empirical field where I studied patient safety practices. So from mid-2014 until mid-2015, I have been doing fieldwork at the following case organizations. The first is a healthcare simulation center, which is situated within a university hospital in Copenhagen. There I followed the development of simulation scenarios and their use in a particular kind of healthcare simulation that is called the role play. The second is a mother-child healthcare facility that is also situated in another university hospital. And there I explored the hygiene of young patients during play and learning activities. And the third area of fieldwork concerned 2 organizational departments that are entitled as innovation units. And each of them is situated at 2 different university hospitals in Denmark, but not in Copenhagen. And in those organizations, I explored how professional designers and clinicians collaborate for developing new devices and services that were out to improve the quality of care within the hospitals or within the regions that these innovation units belonged. And during the early stages of my PhD project, I've also took some interviews and I visited particular places that made sense to actually start inquiring patient safety practices. And some of them is the Danish Society for Patient Safety or the Unit for Patient Safety, which is within the capital region of Denmark, Medico Industry, which is an umbrella organization for medical device manufacturers in Denmark. And I also had the chance to do some additional observations for limited time, where actually I observed some abdominal operations, where I got a good sense of actually how it is to work with patient safety in daily work in situations that something actually may come out, some critical things may come out soon. So I will give you a brief indication of what I was after while studying patient safety practices. So let's see. Yes, this is a case, actually, for holding masks, gloves in different sizes, and gowns. And in the picture, you can see a hygiene nurse who is holding this, the same artifact. And the point is that actually she had observed some kind of what she deemed as to be threatening, or at least to some extent threatening. And the thing is that before entering into an isolation room, clinicians have to wear all these like gloves and gowns and masks and everything. And while they were coming out of the room, they were disposing these kind of things in a way that she found quite threatening. So they were just not just throwing them in the basket, but they were just hanging them on top. So she tried to develop something like this by engaging some designers and asking them to solve her problem in a particular way. So they came up with something like this. So what I was after is to figure out how this thing is put into use in a particular context within a hospital, in a healthcare setting. But most importantly, I was more interested to understand what kind of changes it brings in patient safety practices that they existed before. Scrubbing is not a new, it's not a new patient safety practice, but I was thinking that this may make a difference. So I wanted to understand what kind of difference does this kind of thing make. So now it's time to present some methodological considerations in studying patient safety practices. So during my study, I did not generate data by directly interacting with patients. And the patient became visible in my study through the work of healthcare professionals in the settings that I mentioned before. And for example, in the context of healthcare simulation, clinicians drew on their experiences with critical events that had happened to the patients in real healthcare settings in order to develop simulation scenarios. And in this context, the patient appeared as a matter of translation, where experiences had to be translated actually into actually concrete scenarios. So I followed the patients as long as my primary informants were mentioning or were representing the patient with different artifacts. Then the time that I spent for doing fieldwork was, of course, bounded by practical considerations. It needs a lot of, it takes time from the work of informants. It needs their engagement, and it needs a lot of efforts for coordination. However, I believe that this is not so important as to actually whom you're going to select to follow and to include in the research, and what, maybe. Even not only people, but maybe also artifacts. What kind of artifacts do you want to study? For example, during my fieldwork at the mother-child facility, I approached young patient hygiene during play activities by inquiring the work of a hygiene nurse, of course, because the thing was about hygiene, but also other actors who were involved into the actual play of children, like elementary school teachers, pedagogues, even ward cleaners. And finally, during my fieldwork, I approached particular informants and gatekeepers as sort of mid-terms audiences that would be potentially interested into getting an idea of my early findings in the PhD project. So, for example, at the conclusion of the fieldwork at the mother-child facility, I conducted a workshop only with gatekeepers. And together we explored young patient hygiene and play by drawing on my early findings about the work of healthcare professionals who had a non-clinical background. So during the PhD project, I used part of my empirical material for writing the two articles that you can read in the slide, and these appear as appendices in my dissertation. In the first article, I used empirical material from the case of healthcare simulation for writing about collaborative design in the wild, that is actually settings of use. And the contribution of this article comes closer to the body of literature that is concerned with the ways that information and other types of infrastructures continue to be developed along their use, along their appropriation. In the second article, together with my co-author, Jessica Messman, who is an associate professor at Maastricht University, we developed an argument about the role that non-clinicians play in patient safety and for the limited visibility that they have in current empirical research about patient safety practices. And while this article does not explicitly deal with design it helped me to get a better idea of my object of study, which is patient safety practices. So I'm going to move now to the cases one by one, and I will use each case in order to provide you examples of how artifacts are developed within healthcare settings. So the first case is healthcare simulation, and the example that I will present deals with the development of simulation scenarios. So you can start reading actually the diagram from left to right. So events which are critical for the treatment of patients occur in some sort of healthcare setting and might be within a hospital ward or within a patient room or an operation room. And then within the healthcare simulation center, such events become scenarios that are later used for the training of novice clinicians upon different care delivery skills, or as they call them themselves, non-technical skills, which amongst them, for example, could be collaboration or coordination during an operation. So finally, these kind of scenarios support, as I said, sort of a particular kind of simulation, healthcare simulation, which is called role plays. And I will give you an indication of what is this later on. So in this context, I was interested in the processes through which a critical event becomes a matter of scenario design. So while studying scenario development, my focus was on instructors and their interactions during scenario design and during role plays. Now let me give you an idea of how does it look like to the particular kind of simulation that I studied. Briefly put, on the upper left corner, you can see a simulation room, and what you can see actually is a simulated operation room. And there, clinicians under training, like young clinicians, perform role plays of events. And an example could be, for example, the miscalculation of the amount of blood that needs to be ordered during an operation. On the upper right corner, you can see a mannequin that is situated within the simulation room, and the mannequin performs particular functions like breathing, and these are controlled by clinicians that sit in the control room, and they have the role of instructors. And from there, they observe how participants act upon the critical event and intervene only when there is necessary for actually to do something more, to facilitate something more. And finally, within the control room, instructors use software through which the mannequin can be programmed to perform particular functions that relate to the scenario, to the role play. And here I'm going to show you how scenario design is developed within workshops, and it becomes actually into actual scenarios. So it's about taking a critical event and transforming it into an actual scenario, which has some sort of materiality. So the first step is, of course, that the development of scenarios requires from clinicians, as I said before, to consider the role of instructors and to understand that they are going to be also instructors later on of what they are going to design. And the next step is that during the workshop, the clinicians have to fill up a form, the script form, whose categories describe different aspects of a scenario. And I'm going to give you an example of this. So this, you can see an excerpt of a script form. So during scenario design, the clinicians have to fill up this one. And they have to fill categories which refer to the learning goal of the scenario, the major problem, the case briefing that they have to brief actually the participants, to mention to their colleagues what preparations are necessary for the mannequin or what artifacts may be necessary in the room setup. And here you can read a short case briefing, which is actually given to the participants just before entering into actually a role play. So you can read like, you are the team for the emergency department today. You have been asked to attend a patient in rescue who has difficulty in breathing. So participants enter actually the simulation room just by knowing this thing, and they try to work with the mannequin. So while trying to fill up the categories of the script form, the clinicians, as instructors, they have to reflect upon their own ways of engaging with critical events in real healthcare settings. They share some of those reflections with each other. They negotiate with each other about the content of each category of the script form. And finally, through this process, they create a new script form in which a critical event that once took place in healthcare settings, it has been reordered actually in different categories. And And such new ordering can be seen as a form of collaborative development of a new artifact that lies in the knowledge of clinicians about critical events. Scenario design can also be understood as a practice where clinicians, as instructors, approach critical events as objects of learning and not only as problems that would have some difficulties or some challenges to solve while being in healthcare settings. So now let's move to the role plays and follow the development of scenarios. So a role play lasts for about 10 to 20 minutes, and as I mentioned earlier, participants are situated within the simulation room and instructors at the control room. There, participants are supposed to follow the briefing that they have received earlier from instructors, and instructors have to observe how participants perform the scenario. However, each instructor may give a different meaning to the scenario and follow his or her own objectives about what the scenario should be about. And therefore, coordination is necessary between actually the instructors. And then instructors as a team may have to actually align with the performance of the scenario by the participants, because some participants sometimes act in unpredicted ways that they were not predicted while the instructors designed actually the scenario. Therefore, some alignment also is necessary between instructors and the performance actually. And these are some initial indications that the development of scenarios continues during the performance of role plays, and that instructors relates to such development by actually participating to its performance rather than just facilitating or staging the scenarios. The adjustments that instructors have to do during role plays may indicate the boundaries of a critical event. In other words, the repetitive facilitation of scenarios allows instructors also to gain knowledge about the multiple nature of a critical event or the different nuances of a critical event. So they have a chance actually to depunctualize what is a critical event. This is the last slide of this case, and I will present to you some artifacts that instructors have to develop in order to, in addition to the script form, and actually for dealing with the unpredictable performances of the participants. So these artifacts can be diagrams that inform the participants about the condition of the patient, or like bags which contain blood for blood transfusion during an operation. And instructors call them as props, this kind of things, and use them to bring the scenarios back on track. So where they wanted to land each scenario, despite what the participants may be doing. The point here is that scenarios are not completed during scenario design workshops, and they require the development of additional artifacts that will enable actually their performance. And then a scenario can be thought of as an object that continues to be developed along its use, and the collaborative development of these scenarios with instructors could be thought as a process that continues in additional spaces more than actually the workshops or the role plays, because these artifacts are generated obviously somewhere else in other times. So now I'm going to move to the second case, which concerns young patient hygiene during play at the mother-child healthcare facility. And play and learning activities within the facility rely on the work of various non-clinical professionals, such as pedagogues, elementary school teachers, Red Cross volunteers, librarians, and other non-clinical professionals who work for the facility. Here you can see, for example, two elementary school teachers who actually sing a birthday song for a young patient who is within the isolation room. Here you can see a pedagogue within a special area for play, which is called the playroom. And finally, you can see a witch who is hired, is an actor who plays the witch and is hired by the hospital to entertain hospitalized children at the different wards within the facility. And the children that I mentioned here, they are between 3 and 10 years old almost. In what follows, I will bring one example that shows the development of particular parts of a hygiene process that took place within a special area for play, as I mentioned, and this is the playroom. So here's how a playroom actually looks like. Within a playroom, there are different toys, and there are also material for handcrafts and books, and also for reading and other kinds of stuff which we consider as toys. So from 8 to 4 and from Monday to Friday, there is at least one pedagogue in each playroom who motivates actually young patients to play, and sometimes she or he also plays with them. And after the working hours of the pedagogue, young patients and parents, they still have access to the room, but they can play unsupervised, and the use of the room, it belongs or it depends completely on the parents. So within each playroom, one will find a set of red and green boxes, such as those in the pictures, and the red box is intended to hold unclean toys, while the green box is for storing the clean toys. And this system was introduced to each playroom by the hygiene department, and it is based on the idea that toys become potentially contaminated during their use by young patients. Simply put, the use of the red and green boxes requires from pedagogues to separate toys into clean and unclean, to store them in the boxes, and to make toys available for cleaning at special areas outside of the playroom. And this has brought different challenges to pedagogues. One of them is that used toys are often many more than what actually these boxes can hold. And another is that the use of toys, and therefore the production of potentially unclean toys, it continues after 4 o'clock that they actually finish work and they go home. The pedagogues approach such challenges by introducing various artifacts and involving more people that I will briefly present you in the next slides. And the general idea, which you can keep for later, is that all other artifacts came after the introduction of the red and green boxes, and therefore created a sort of another kind of a new order of hygiene that was not just dependent on these two boxes. So one pedagogue has ordered and placed a rack. This is a rack within a playroom for dealing with the limited spaces for storing clean toys. And in doing so, she was able to place toys within boxes, which you can see that they are within the rack, according to categories that she thought that fitted actually or made easier for the young patients to grab the toys. So she put, for example, dolls together with dolls, or like toy cars together with toy cars, and so on. But before placing the toys in the boxes, the pedagogue had to actually transform each of these toys from a potentially contaminated artifact into a clean artifact. And for doing so, after each play activity, she was wiping the surface of each toy by using special disinfection napkins, where you can see there. And such wiping came as an additional way of cleaning toys, because the primary way of cleaning toys was the daily collection of the toys from the playrooms each evening for a thorough bath in special facilities. And in charge of this process is a ward cleaner. So what we actually we see here, it's a sort of a double process of cleaning. The point here is that the limited space for the red and green boxes and the approach of toys as clean or unclean led the pedagogue to involve additional artifacts in young patients' hygiene and to initiate a new process through which artifacts would be used. But even after the introduction of the rack and the boxes and the napkins, the pedagogue still had additional challenges to deal with. And for example, she found it challenging to communicate the use of all this system to parents that they would visit for first time the playroom while she was not there, or for parents that they are a bit, they just forget from time to time of how to clean toys. So for dealing with such challenge, the pedagogue developed signs which she hung on top of the red box. Here you can see a sign where actually explained to the parents, or they aimed to explain to the parents of how actually what to do after the kids playing with toys. However, after some time, the pedagogue observed that the sign received limited attention by parents, and therefore she doubled the sign, so she put another sign next to it. And she also painted the wall, one wall of the playroom blue, to create what she called a hygiene corner. And there are 3 points to be made here and to conclude this case. The first is that the introduction of new artifacts and processes for producing clean and unclean toys may generate double processes of cleaning. However, this kind of process, the new process at least, involves new actors, and therefore it leaves some space for uncertainty of what actually, of whether actually toys come out clean after this process. But it's more about, it's not a matter of understanding if something is safe or unsafe, but it's about understanding all this involvement, what kind of, that it creates sort of uncertainty. While the introduction of the red and green boxes was initially approached as a hygiene procedure, the actual cleaning of toys required the coordination and communication between the pedagogue and the parents. So we talk about the non-clinicians with people that they occasionally visit the hospitals, and hygiene department seems to be nowhere there. The third is that the synthesis of use practices that are required for actually putting this kind of thing into work lies upon the work of pedagogue, and who is, again, a non-clinician, and not upon the hygiene department, who introduced the initial system of red and green boxes. So I'm going to move now to the case 3. And I did the third part of my fieldwork at the two different innovation units. And briefly put, an innovation unit is an organizational department which is situated within the premises of a university hospital. And innovation units are staffed with design engineers, with IT specialists, with public administration employees, project managers, who all work toward the initiation of projects, which this kind of projects aim, or at least they have as an objective, the better delivery of, to increase the quality of care within the hospitals and within the regions that these innovation units actually are. So by drawing on interviews that I made with designers at innovation units, I will shortly present you one way that new objects of design, be they new artifacts or services, are generated within hospital settings. As you may see in the picture, the main idea is that IU designers can collaborate with clinicians who work at the hospital. So the idea that what needs to be designed is not clear from where exactly it's generated. It might be, for example, it might belong to a clinician who have faced a problem again and again in his or her daily work, or could be also a part of a designer's approach to healthcare settings who would identify areas for improvement. But no matter where the idea comes, the next step is the communication between the designers and the clinicians. And designers may firstly visit, for example, particular areas of the hospital in order to collect data. And this data actually refer to the context where they have an idea that something new will come and will change at least the way that hospital works. Then in user involvement workshops, clinicians are invited to participate as experts of their own workplaces, whereas IU designers consider themselves as experts in facilitating these user involvement workshops. On the one hand, the object of design in this kind of workshops, it becomes clear, so people have a better idea of what is to be designed. On the other hand, patient safety becomes an area where it's out to be improved through the necessary introduction of a new artifact or a new service. So there is no way to get out of this process without having something new, or without having something new. It's not about figuring out what already works, but it's about always bringing something new. And what is important here is that the designers become participants in, or they facilitate the development of such artifacts, but they also participate in potential reconfigurations of patient safety practices, especially in cases where the artifacts that they are to be designed have the explicit, or they are developed under the explicit aim of improving safety or quality. Yeah. So now I'm going to move to the last part of the presentation. And firstly, I'm going to present you a summary of the findings under 3 categories. One is called objects as projects. The other one is called temporary spaces. And the other is called materiality and tinkering. Then I will conclude the presentation by shortly discussing how such findings may inform a generative framework for identifying collaborative design processes in healthcare settings. In the last slide, I will focus on what is the role of the professional designer in all this. And here is a summary with the findings of all cases. Under the category of objects and projects, I have placed the main artifacts that I referred in the examples, and there you can see that most of these artifacts entail various projects. So, for example, the red and green boxes were supposed to hold clean and unclean toys, but the actual work, it was actually how to make these things, the toys, actually clean or unclean. So it's about cleaning and uncleaning. Then under the category of materiality, I have placed the set of artifacts that were required for the actual use of the objects that I mentioned before. So for example, the use of script forms required the manipulation of mannequins, but also scenario-specific props that were developed at later and other stages. Under the category of temporary spaces, I have placed the spaces that simultaneously supported the development of artifacts and the reconfiguration of safety practices where those artifacts became elements of. So for example, the initiation of workshops within hospitals allowed designers to come closer to the needs of clinicians, but it also allowed them to sort of intervene into patient safety practices. So let me move on now and explain how these observations may lead one to identify how collaborative design processes take place in healthcare settings. Again, I have named the first element of the framework's objects as projects. You can see the names are almost the same. And it is about recognizing what are the objects of design that are at play in the daily work of healthcare professionals. And while trying to recognize, one needs to at least remain reflexive about his or her own approaches to the daily work of healthcare professionals. For example, would it be fair to call the pedagogue as a user of the red and green boxes? Yes, she was a user, but she was more than that. She was actually generated a whole network of other people and other artifacts in order to make actually the red and green boxes to serve the purpose of use. So therefore, she was a user, along with many other things that place her as a participant in a broader process of development or design, if you like. I have named the second element of the framework as materiality and tinkering, and it is about paying mutual attention to the material properties of the artifacts that finally constitute an object of design, and to the experimental processes that are involved in the work of healthcare professionals. One may identify these experimental processes by focusing on how healthcare professionals introduce artifacts in their work context for achieving what it was previously thought to be possible, but in reality it was not. So for example, scenario workshops are considered as finished as soon as the script form is filled, but the scenarios cannot actually fill their purpose of facilitating alone or themselves role plays. And what I gathered there as experimental process is all the other things that they have to add it in order to make things work. And the point for those who have design as an explicit concern is that healthcare professionals are capable actually for synthesizing. And the important difference is that designers are able or should be able to appreciate the effects of the synthesis that they initiate or they participate in them. So the next step is to figure out how to appreciate the role of healthcare professionals in the synthesis that they take already place. The third element I have named temporary spaces and metamorphing, and it is about becoming aware of the configuration of spaces where design continues after it has formally ended. The idea of metamorphing might be a bit more engaging term than configuration because it allows us to consider healthcare professionals and designers together as participants in emerging objects of design and less as stakeholders who hold actually different truths or opposing views upon a particular object or a particular artifact. In this way, temporary spaces allow designers to understand better the learning processes that takes place in the context that they aim to intervene by introducing new artifacts. And I will conclude the presentation by actually posing a short question and giving a very short answer. And the question is that somebody may ask, for example, why do I need to understand how collaborative design takes place within healthcare settings? Or why do I need to consider all these trade-offs between design and use? And my very short answer, which I conclude the presentation, is that if we accept that artifacts become developed outside of the professional design realm, then we should also consider potentials for learning about design from all these other areas. Thanks. Thank you.